the reason why OR resuscitation started was because a lot of studies in the past show that delayed transfer to the operating room was one of the areas that people could improve on. But you're talking about a time where transfer times to the operating room were upwards of 30 minutes to an hour. So one of the ways that some institutions decided to try and improve upon that was to take these patients and try to identify those patients who would most likely benefit or most likely going to undergo an operation, and therefore directly transport them to the operating room and bypass that time in the resus room. We started doing this in 1984, and for those of you who don't know this man, this is Dr. Hoyt, who recently left us to go to UC Irvine to be their chairman. It was him and Dr. Shackford who put the protocol into place here, with the help of a couple of the ICU nurses and trauma nurses, actually. And he wrote one of our very first papers about a year after we started this protocol and identified that there were some patients who actually did benefit, it seemed to be, just within that first year alone. So what are our triage criteria? What determines which patients are going to go straight to the operating room? One is CPR in progress after traumatic arrest. So anyone that the EMS folks see that have arrested in front of them and they are actively doing CPR, all these patients directly go to the operating room. Anyone who has persistent hypotension, and according to the protocol, if you look at the protocol, it says systolic less than 100. We've recently been using less than 90. Unresponsive to fluid resuscitation. And what this means is they give them 2 liters of fluid, they don't get better, and they go straight to the operating room. This one's a little more difficult now. Now that our transport times are less than 10 minutes. It's very hard to get 2 liters of fluid into a patient in that time period. Amputation, or specifically uncontrolled external hemorrhage requiring immediate operative treatment. So the EMS calls you and says, this guy is squirting out blood from his leg in a pulsatile fashion. Those patients all go straight to the operating room. Penetrating torso injury, so chest and abdomen with hypotension, and anyone with a difficult airway. So those guys who come in with massive facial trauma, who you think you may have to do an operative procedure to get an airway, those patients will go straight to the operating room and bypass the emergency room. So how does this happen? The report is called into the MICN by the EMS. Based on the report, the MICN or the resus nurse may elect to make the patient an OR resus. And these are the 2 people who mainly are going to make that determination. Sometimes it's made by the MICN just based on the EMS report alone. There are some times where it's fairly obvious. Now, if our current policy is greater than 5 minutes, if you have a patient who they initially call you, is it 10 minutes now actually?
No, it's actually, there's no time frame on the initial call for an OR resus.
No, I know about the initial call. So if somebody calls and says they want to make it an OR resus, that's fine. If they call back with an updated report and the patient is still more than 5 minutes out, you can elect to change that person from either trauma resus to the OR or vice versa. Make them go from the OR to the trauma room. The initial call, sometimes they'll tell you there's no blood pressure on the patient. Then the second call comes in 2 minutes later and says, oh, we just couldn't get one because we didn't try. And the blood pressure's fine, the guy's awake and talking. And that's when you can say to yourself, okay, we'll switch him and we'll make him a regular resus. Now the reason the 5 minutes is in place is because it takes too long for us to get from one place to the other. So if they are less than 5 minutes out and you've already determined where they're going to go, don't change it, only because it's too hard to mobilize everybody. To try and get the entire trauma room, trauma team back from the OR to the resus room or even the other way is just too difficult. Sometimes the paging operator doesn't even get the page out in 5 minutes. So if it's less than 5 minutes and you've already set a place, just leave them at that place. And having these patients go to the resus room is not necessarily a bad thing. You have to remember, most institutions in this country do it that way. They all go to the resus room. So for us, going to the OR is a luxury more than anything else. So like I said, once you make the decision, don't change it, because it's difficult to mobilize everybody once it's been set into motion. Now, there are a couple of exceptions that you will have to make the decision on using your own judgment. These are not officially in the handbook if you look at the protocols. One are those patients who have isolated penetrating head trauma, like a gunshot wound to the head, who are in traumatic arrest. This is a little difficult because sometimes they'll tell you there's one gunshot wound to the head. Well, you're not looking at the patient, you don't really know. Is this a tangential wound that hit the head and they've got something else going on in the chest and abdomen that's making them hypotensive? Who knows? Now, if they call you and say, well, there was brain matter everywhere, or then you may rethink this and decide that they probably won't benefit from going to the operating room. But this is one scenario where you're going to sort of have to use your judgment and decide where this person would best go. If this is the other scenario that apparently has come up recently in the last couple of months especially, if you have a time where as in like a massive casualty, where you're going to have more than one patient who comes in who does qualify as an OR resus, you are actually better off having them all come to the resus room, especially at night. During the day, it's not as much of an issue. There's 4 attendings here, 2 fellows, an entire trauma team, and more than enough resus nurses to take care of some of the stuff that comes in. Especially at night, you can talk to the attending, but more than likely what they will do is have everybody come to the resus room. It's easier to mobilize your resources. You can bring everybody to the resus room. It's a bigger room to work in. And for the attending, it's easier to be in one spot rather than running back and forth from the trauma room to the OR to back to the trauma room again. So just for ease of management, this is probably the better way to go. So just so you guys are familiar with our numbers, the red line is actually how many patients we've admitted up until 2005. We usually average about 2,000. This past year we went just over, I think, 2,100. But you can see that really over the last year, this is the percentage of OR resus that we've done per year. We really have stuck around about 2% every year, and our numbers don't really change that much. We've only done about 50 resuses, OR resuses a year. Somewhere between, some years are a little bit higher than others, but for the most part, somewhere between 50 and 60 a year is what we average. So it's not a huge number of patients. Just keep that in mind. So why do we do this? So Dr. Steele, when he was a fellow back in the 90s, actually looked at our first 10 years of data, so 1984 to 1994, and found that there was actually an improvement on probability of survival. There is a scoring system that you can use based on the vitals that you see at the field and at the scene and on admission that can sort of help predict what is their chance of surviving. And we actually found that based on those numbers, we were actually doing much better than what is predicted for those patients. And when he looked at all the data, really it's those patients who had penetrating injury and low blood pressures that had the greatest improvement in survival. And that's the same group of patients that Dr. Hoyt found during the very first year that they had instituted this protocol. So I actually looked at the last 10 years, so the last 10 out of the whole 20 that we've been doing this. And I sort of did the same thing, only I looked at it from a little bit differently. I tried to find a comparison group. Now it's a little hard to find a comparison group because you assume everyone that goes to the OR is going to be the sickest of the sick. But there are a couple of times where people show up in the resus room that are actually a lot sicker than you think they are. So I took all the patients from both groups who had systolics less than 90, so everyone who presented with initial hypotension. And I only bring this up just to sort of bring up a point of, just to show that we actually, for the most part, we're actually doing pretty good in predicting, the sick people. They have greater injury severity scores. They have lower blood pressure. So for the most part, we're pretty good at sending the right people to the OR. Blunt trauma patients, you will see, they don't do well. The ones that come in, they're much sicker. They're significantly sicker, and they don't do well in the OR, and they probably won't do well no matter where you put them. So sending them specifically to the operating room may or may not benefit them. It's sort of not clear at this point, and this may be a group of patients that we take out of the protocol. We sort of haven't sat down and talked about this yet. So those patients who come in after falls or bad motor vehicle accidents, whether or not they come to the resus room or go straight to the OR, it may or may not benefit them. It's just not clear. This is a group of patients where I think they should still all go to the operating room because I think these guys actually do benefit. If you look at our numbers, we have patients who are significantly sicker. Their survival is not, even though it's not statistically significant, it's a little bit higher, but it's at least the same. So you have sicker patients going to the operating room who have equal, if not maybe better survival than those patients who go to the resus room. So I think this is still a group of patients who still warrant a trip to the OR as an OR resus. And you can see that really it's the gunshot wound victims that seem to benefit. So, but regardless, you still see, I think you still see a benefit in the stab wound patients too. So we're going to go over just a couple of scenarios because I know there's been some confusion about which patients should go and which ones aren't. So the MICN calls you. It's a 20-year-old guy who was shot in the belly. His initial blood pressure is 80/40. His pulse is 130. His estimated time of arrival is 10 minutes. How many would send them to the OR? How many would send them to the resus room? Okay. But you're at 10 minutes, so this is your cutoff. You've got to, because once you've made the decision at 10 minutes, you can't change this. So where are you going to send this? And say that they told you they've given them a liter of fluid already, and this is still their pressure. OR. Okay. So OR. Okay. Now, there are going to be some times where they've told you that they haven't had a chance. Maybe they've only given 500. It took them 5 minutes just to get the IV in. The guy's thrashing around. They don't know what to do with them. So.
This is a young guy, too.
Yeah, this is a young guy who's got a pulse of 130 and a blood pressure of 80/40. He's bleeding from somewhere. if this is truly his vitals. So even without the 2 liters, I think you're still okay sending this person straight to the operating room. So this is the next one. 37-year-old male, rollover MVA, 1 passenger has died at the scene. His initial vitals are blood pressure 120/80, his pulse is 130. His estimated time of arrival is 20 minutes. How many would send him to the resus room? How many would send him to the OR? So this person probably for now is okay going to the resus room, right? They have an okay blood pressure. Their pulses, they're a little tacky, but maybe there's just a little bit of excitement going on. So we'll see, but there's still 20 minutes. So you have time to change this if you need to change this. If they call you back saying, you know, things really are not how they seem. So he calls back. Things have changed. Blood pressure is 80/60, pulse is still 120. OR? Resus room? OR? OR. So you're probably okay sending this person to the OR. Now, looking at our data, maybe, maybe not, but for right now, according to the protocol, this person goes to the operating room. Okay. This one, 35-year-old female unrestrained driver in a motor vehicle accident. They're unable to get a blood pressure or a pulse. They start doing CPR and their ETA is 5 minutes. Where are you going to send this patient? Show of hands, OR? Show of hands, resus room? Okay, so for right now, this patient qualifies as an OR resus. However, this is probably a patient that it probably doesn't matter if they go to the OR. If they found them in arrest, it probably won't benefit them to go to the operating room, because really the only maneuver that you may do that may save this person initially is perhaps bilateral chest tubes or if they've got tamponade, if by some chance they've got tamponade as their only reason, is just doing a pericardiocentesis. Both procedures you can do in the resus room. I think it's still okay to send this person as an OR resus, but if you do get the report that they found them dead, they're just doing this and they haven't gotten the okay to call them in the field, then you have to use your judgment and decide where is this person best served going. They have to call the emergency department actually and get the okay from the ED. So if the EMS gets somebody and this person is in arrest and they think that they are not salvageable, what they will do is call the emergency physician, the ED physician, and say, I have this person, describe the scenario, and the ED physician, from what I understand, is supposed to be the one that gives the okay to call the person in the field. There have been a couple of circumstances where the ED physician has said, I will not call this person in the field, you need to bring them in. So, and all of you have been witness to that, where a couple of times we have somebody comes in, they said, well, you know, we had that one guy who came in about an hour after his injury because he was in arrest because the ED person said, I am not calling this person. So it does happen. It doesn't happen that often, but it does happen. But this is, you know, I don't think this one's as clear. You need a little more information, I think. You need to know a little bit more about what happened to the person. I don't know that right now you would be faulted for sending the patient to the operating room without additional information. So for right now, I don't think it's the wrong thing. Now, like I said, if they call you and say, you know, we've been doing CPR for half an hour and we're on our way in, then that's a different scenario. But if this is someone who they just got to, that this happened, you know that they probably didn't arrest for longer than, 2 or 3 minutes. If they were, maybe they just happened to see it and they happened to go by as this person was getting into their car accident. So you do need a little more information, but this is one of those scenarios where you're going to have to sit and think and decide. You don't have much time to sit and think and decide, but you're going to have to make a determination. I actually had to do the in-service yesterday for the OR nurses, for OR resusces, interestingly. And one of the issues was the fact that sometimes these patients come in and they literally sit around for 3 or 4 hours waiting for the coroner to come. So my plan actually is to call the coroner. I'm going to talk to them about these patients who come in basically dead and stay dead, whether or not we can have a designated place that these people go to so we don't have to keep occupying our beds. Part of the problem is that when you get busy, sometimes the resident or the attending calls and then they leave the room and then they haven't had a chance to talk to, the OR nurses haven't had a chance to ask them, can we move this patient or not? So I'm trying to figure out if there's a way to just make it part of the protocol. Someone comes in dead, stays dead, we don't do any procedures on them. Is it okay to just immediately move them to, say, the pre-op area or some other area so that we don't occupy an OR or we don't occupy one of the resus rooms, resus beds? But I don't know how that's going to work, so we're going to have to talk it over as a department and then talk to the coroner about it. So, but that is something that was brought up yesterday. So, how do you run an OR resus? Just like any other. It's no different. A recess is a recess is a recess. And I think this is one of the things that it has not become clear to the residents yet, because I think actually the residents are probably the ones that have the most difficulty trying to cope. When anesthesia gets there, they have to stay there, which is why it's at no air recess, so that they can have access to the airway. However, I think it disorients the residents, because then they're like, well, we can't stand at the head of the bed. How are we going to get around and maneuver around everybody? So we're trying to stress to them that there is no difference. No matter where you are, a recess is still a recess. If you're in the emergency room, a recess is still a recess. Your ATLS protocols have not changed. So you just have to be aware of your surroundings. They're a little bit different. So number one, if you guys don't know, we're in a different room. It's in the operating room. It's OR number 11. The other thing is there's more people. Sometimes there's more than just who's supposed to be there. There's a lot of spectators, there's a lot of gawkers, there's EMS, there's police, there's whoever else in the hospital that happens to see this bloody patient roll into the operating room. So there's the usual people, which is you guys in the trauma team. There's the OR nurses. There's the OR scrub techs. There's the anesthesia staff. And I think that's more than enough people in the room. So in case you guys don't know, when you walk into the operating room, there's two main doors that lead to the ORs. This is actually the second door that leads to the OR. You walk in. Now, over on this left side is where the extra cart and where the OR cart is. And there's apparently, they're named, I forget what their names are. Stan and Rover. Oh, I see. So OR 11, you walk in. This is Stan, which is one of our carts, and actually stocked by us, I think, right? Yeah. This is the OR side. Anesthesia stands there. Techs have their space. So this is the room. And I bring this up just to orient those of you guys who haven't spent a whole lot of time in there, because we're going to talk about this just a little bit. So this is part of the room setup. So this is where the patient will come in, be transported, and actually lay on the OR table. This side is this. This is basically where the OR techs and the OR nurses do all their stuff. They have to have access to this computer because the OR nurses have a lot of charting that they have to do. This is the OR table, and this is the side that the OR techs get really fussy about because of sterility. I know there's been a lot of issues about trying to get people to stay away. What I've asked the OR techs to do is to not break down that equipment until we know whether or not they're going to do an operation, especially the experienced ones. Now, the ones that are inexperienced, they may need more time, so they may end up breaking down earlier than we would like. But for those people who are very experienced, and we have a couple of OR techs who are very good at what they do, they can break this down and have it open and set up in less than a minute. So I've asked them that if you can delay doing that so that we don't have to worry about sterility, if you could leave the packs as is. And the other thing, it's expensive to redo these packs. So that would actually help maybe cut down on costs as well. So, and you know, it usually takes us at least a minute or two anyway to even just get the patient intubated, set up, draped, or not draped, but you know, prepped and everything else done. It takes at least a minute or two to even do your primary survey and your ATLS. And within that time, it's usually fair, for the most part, not always, but for the most part, it's usually fairly clear who's going to need an immediate operation and who isn't. So that's one of the things that I've asked them to do in order to try and not cause this chaos in terms of what stays sterile, what doesn't stay sterile, who's going to run into what accidentally. So this is Rover. And this is the extra cart that's actually, this is our trauma cart, in case anybody doesn't know, that has all the equipment for the operating room. So for if there's anything that the surgeons need for the case, this is the cart that they usually go to first. And that's on the left-hand side of that hallway as you first walk in. Now, so from the top, this is the OR desk where the nurses work. The OR nurses do their charting. This is their OR table. This is where the patient lays. This is our cart. So this is Stan. The door is here. Resus nurses are in their usual spots. Anesthesia and the ventilator. Now this is a problem because this can't ever move. And so you're sort of going to have to work around this. And you may or may not have to find your own way of doing that. But this can't move. They won't move. No matter how much you ask them to move, they won't move. The only thing they will do is leave once they know they won't have to intubate the patient. So it's just something you're just going to have to be aware of. The trauma team is there. This is Ron or Vince or Victor, person that runs around getting everything. So, and these guys are really good at making sure that all the appropriate paperwork that we need, including massive transfusion protocols, gets done. And they will run all your labs. They will go to the blood bank, get blood for you. So that's why I put them a runner, because they're usually doing that. OR techs are usually up there. The radiology tech is usually running all over the place. EMS comes in, they'll drop off the patient, then they leave. Now the only problem with this room is that because of the patients that come in, you sometimes will end up with cops. It's okay to kick them out. Just so you know, if you need to make them leave, make them leave. This room is tiny enough as it is, and there's already a lot of people in there. And if you just look at these numbers, this isn't even. I mean, I neglected to put the attending in here, so you're dealing with probably at least 2 or 3 anesthesia persons. 1, 2, 4, sometimes 4, 5, 6, 7, 8, 9, 10. I mean, that's 11 people in this little tiny room, not including the patient. So just keep that in mind. So, anyway. Any questions? Anything you guys want to talk about?